So welcome everyone to the International Interprofessional Mentorship Program. My name is Kate Barlow. I'm the founder and will be the host for today's meeting. It's July 20th, 2023. And today, Dr. Colleen Craven and Dr. Jessie Franco are here to talk about occupational therapy in acute care. Please keep yourselves on mute throughout the presentation, and there will be a survey link in the chat for you to receive a certificate of attendance. So thank you all for coming today, and I am so excited to have you both. Thank you. Please take it away.
Okay, so again, my name is Jessie Franco, and our topic today is OT in acute care, best practice, and how to be prepared. I do want to apologize in advance. I am moving today, so hopefully it's not too loud, but if you hear lots of extraneous noise, it's just the movers. But a little bit about ourselves to start. I am a senior occupational therapist and I work at a level 1 trauma center in Boston, Massachusetts. I have 11 years of experience working with primarily the adult population in both the rehab and the acute hospital setting. I recently completed my post-professional OTD at MGH Institute of Health Professions, where I explored therapist preparedness for working in the neuro ICU. I created a website with that. We have this link at the end of our presentation. And then more recently, I've had some adjunct lecturer roles in Boston area universities.
And just briefly, I am Colleen Craven, and I also work at a level 1 trauma center in Boston, Massachusetts, actually right across the street from Jessie's hospital. And I have 8 years of acute care adult experience and completed my post-professional doctorate with Jessie, and that's how we became connected. I am founder and chair of a Massachusetts acute care.
Hey.
And I am committed to and passionate about interprofessional education and collaboration as well. So this is a super exciting opportunity. And a little caveat for myself, I have 3 kids potentially in the background as well. They're with Grammy now, but if you see a little face pop in, apologies in advance.
Okay. So we're going to see if this works. We wanted to first kind of see if we could maybe get a grasp of who was in the audience with us today. If anyone, and then if it doesn't work, that's okay. But if people are able to maybe scan the QR code or go to the website menti.com and then enter the code. We had a few different questions that we were hopeful that people could answer. We'll give you a minute to scan.
Sorry, and while people are doing that, I don't have the ability to mute people. So if you can please keep yourselves on mute, that would be fantastic. Thank you.
Okay, so our first question is mainly to see where everyone is. Are you a student? Are you practicing? Are you OT or OTA? We have a little more time. Great. Okay. Well, just for time purposes. So mostly OTs. Another question was mainly just if you could put maybe where you're joining us from. Right, we have UK. Perfect. USA. Now we have a few other likely places. Okay. Go to the next question. Just to get like years of experience that people have coming to this presentation. Right, so 1 to 3 years. It seems that we have 2. We'll keep going with this, 2 participants. Current practice setting, kind of just to get a feel. Are people working in the hospital setting or different? It's great. Hospital. Perfect. And then one last one is just comfort level for the acute hospital setting. I know our presentation is more geared to that topic. Great. So pretty comfortable, but still have things you want to learn. Perfect. Thank you for participating. Okay. So today's presentation is going to focus a little bit more on best practice and then maybe some more specific ways to prepare to work in the acute care setting. But we do want to refer you back to Dr. Jennifer Nordstrom's acute care webinar that was part of this series. Hers did a really great job of going over OT's role in acute care. So we included a link to her presentation through the QR code. You can refer back to that. So we're going to start kind of discussing best practice. So kind of what is it? What are some limitations? What are some ways that you can maybe infuse best practice into your OT practice for the acute care setting? To start, there are definitely some limitations for everything that we encounter, but specifically limitations to best practice can include use of occupation in acute care. There is limited research on occupation-based practice in the acute care setting specifically. The evidence that does exist suggests that although OT practitioners value this occupation-based practice, they do not consistently implement it in acute care settings. This could be due to the medical model, with many OT practitioners in acute care conforming more to this approach, using more biomechanical frameworks. So subsequently, we're going to provide more of that impairment-based therapy rather than occupation-based therapy. As acute care OT practitioners, we can understand our distinct value and contributions to care within the hospital setting, but there are sometimes feelings of being misunderstood or maybe others not fully valuing our role or understanding the importance of occupation or the ways that we could maybe infuse that into practice. Thus, we might not be supported, or we might lack confidence and familiarity to like advocate for the more specific way that OT can work or to help encourage occupations in the hospital setting. This can also be tied to like kind of the walk versus the talk. So there's one study that suggested that acute care OT practitioners are more likely to discuss occupation with clients rather than actually engage in occupations. So this all ties into using that medical model. It's also compacted by limited resources. So within the hospital environment, there are maybe limited resources to engage patients in occupations or any tasks in particular. So if we're going to do tasks, they might not be the specific occupation-based ones that patients would like to engage in. Like we can't have access to those supplies like actual clothing items or engagement in functional tasks that they would really like to do. Like we're not going to bring golf clubs into the hospital setting. We're also just limited by what's available or the types of standardized assessments and measures that are available in the hospital setting. And then the last part is just the overall hospital logistics. So that will be the medical acuity of the patients and overall time constraints. The time constraints in the acute care, as well as the patient's acuity and their overall variability in medical status, is going to limit our ability to plan and then implement longer assessments or treatment sessions. You might have to stop a planned session due to medical inappropriateness or change a plan mid-session, giving the variability in the patient's presentation. Additionally, they're probably going to have some necessary medical procedures, labs, or imaging that might interrupt the session if transport arrives to take them to a test. We also have those infection control protocols, which are going to limit our ability to bring in certain items into their room. This could be just any of those ADL or occupation-based materials, but also assessment tools. And we're all just complicated by productivity demands and then overall staffing challenges. So when we think about best practice, we broke it down into these 5 different categories, which we're going to go through more in depth. But we have interprofessional collaboration, confidence and advocacy, communication, evidence-based practice, and then using occupations. So care within the hospital is interdisciplinary. The patient will interact with and receive care from a wide variety of providers. As the OT practitioner, you may interact with many of these providers, and it's important to be aware of their roles and what their role on the team is and who the patient might see and interact with. To the observer, the care provided by these various practitioners might seem very chaotic and disjointed, with some assessments repeated multiple times a day or by different disciplines. But as the OT, oftentimes we can help play a role in educating the patient and kind of helping them understand their care. Within the hospital, there is a hierarchy of physicians who are providing care for the patient. So you have the attending physician who might be responsible for planning and the execution of the patient's medical care. And then below the attendings, we're going to have more of those physicians in trainings who are responsible for reporting to the attending doctor. But these can include fellows who might have several years of medical training, or medical residents or interns who are more in the earlier stages of their training. As the OT, we're going to communicate with the medical team, but it's typically going to be with the medical residents or the interns. The key part of all this is just, it's important to remember that the residents are still learning. So they might have little knowledge or understanding of OT and our specific roles in the hospital setting. Some of the other team members who might be involved in the patient's care include the nurse. This could be the ICU nurse or the bedside nurse providing that direct patient care. We also have nurse practitioners who kind of serve a similar capacity as the medical residents under the supervision of an attending physician. We have a case manager who's usually more responsible for coordinating discharge planning, arranging rehab referrals. Typically, we interact with them to communicate and collaborate with to help facilitate discharge for patients. We have social workers who can kind of also assist with discharge planning in some settings, but typically they're more there to address those psychosocial needs of patients. And then some other providers you might interact with would be other rehab professionals like physical therapy, speech therapy, also dietitians, respiratory therapists, or chaplains, or spiritual care. In practice, interprofessional collaboration can take several different forms. This could be interprofessional rounds, having that shared decision-making. It could be interdisciplinary care planning and team meetings, and team-based interventions. These strategies are going to be supported by education, training, and then effective interprofessional communication. Kind of with all these approaches, the team members are coming together to share information, exchange expertise, and then collaborate to develop and adjust care plans. This is just to help ensure seamless treatment, to optimize patient outcomes, and promote continuity of care. Then we move to confidence and advocacy. The OT practitioner needs to be confident in advocating for their role on the care team. A critical component of good communication is going to be confidence in content and then competency in your ability to advocate. As the OT practitioner, you must fully understand your role and scope so that you can then clearly explain it to those around you. But if you're unsure of your responsibilities, you would not be able to advocate for yourself that well. So you kind of need to educate yourself so then you can then educate others and better advocate. You'll find great variability among all those team members we just mentioned in their understanding of occupational therapy and our role in the hospital. So in addition to kind of advocating for your role to patients and families, you also have to advocate to other team members. So there's a lot of advocating that has to take place for all different people involved. Then we have communication. The acute care OT practitioner must be an effective communicator, as you will constantly be educating and then making recommendations to patients and their families, as well as other members of the patient's care team. It's important to feel comfortable and confident with asking clarifying questions of physicians, nurses, and other medical team members to ensure that safe and effective intervention is provided for each patient. This can include discussing a patient case with the nurse or asking questions prior to evaluation and treatment. This could be confirming or clarifying with a resident what the patient's activity orders or restrictions are, and if these are accurate. And also discussing performance with the case manager or other providers, maybe the resident, and then communicating your discharge recommendations. Clear communication and robust collaboration contribute to healthy and effective teamwork and care provision, whereas barriers to successful communication can result in medical errors. When communicating with the team, you want to make sure that you're providing concrete recommendations and examples to support your rationale. You want to advocate for your case. Typically, if you tie this to an outcome the provider cares about, that can be helpful. You want to make sure you're asking appropriate questions. So who knows the information that you want to find? Is it something that you could ask the patient's family member, or is this something you need to ask a different medical provider? So kind of knowing where the information can be found. And then making sure you're communicating with the appropriate provider. So which member of the patient's team do we need to talk with? Is this an orthopedic question? You might want to contact one of the orthopedic medical residents, or are you just trying to communicate information about discharge, and that could maybe be with the case manager? When you're communicating with patients and their families, you just want to be sure to limit your use of medical jargon and help break down the recommendations or any information you provide so that they can fully understand everything you're telling them. There are definitely some barriers to communication, which is going to be the productivity demands of the hospital, which is going to limit our time to maybe thoroughly and effectively communicate with the patient, but also other members of the team. And then we also have, this can lead to maybe some feelings of being misunderstood or being underutilized. So productivity and definitely impacts your ability to effectively communicate. And then also that knowledge piece of maybe not everyone understanding your role as OT can kind of limit their understanding of what you're telling them. Communication also does include clarity and value of your documentation. So it's definitely like the verbal communication you engage in with the team or patient, but also your written documentation that you're communicating. So you want to make sure that you're documenting OT's uniqueness, which can be a little bit challenging, but it kind of highlights the direct relationship between the patient's goals and their abilities and your rationale for why you're providing these discharge recommendations. Then we have evidence-based practice. So what is evidence-based practice? AOTA has applied this definition to our own practice by explaining that evidence-based practice is the integration of critically appraised research results with clinical expertise, the client's preferences, their beliefs, and values. So this definition shows that evidence-based practice isn't just reading a research article and deciding that you want to try this technique that was described, but rather it's a careful analysis of evaluation and treatment methods addressed in the body of recent research and how those methods can be applied to the care you would provide to your patients on more of a case-by-case basis. So one treatment technique might not fit every patient you have. This is going to lead to more effective treatment techniques. Evidence-based practice is going to help to ensure that your treatment techniques are effective. Analyzing the best and most relevant research is going to help ensure that the treatments you use with your patients actually work. You might get better cooperation from your patients. This is going to allow for you to help your patients make more informed choices for their OT programs, and might help you to more easily answer the question when the patient asks, why do I have to do this? The evidence behind your treatment techniques will help you to show your patients that there's a point to their treatment. Additionally, evidence-based practice can help build confidence in advocating for the profession among interprofessional colleagues, and then advocating for our role in particular cases or treatments. Often we might get more buy-in from a physician or other members of their team if we're able to substantiate our practice with research. And then lastly, evidence-based practice is going to help keep your OT skills current. It helps ensures that your clinical skills are up to date We know that the practice of OT definitely changes over time, and that techniques learned in school might not be the ones supported by the current research. And then the last part of this is just using occupation. So when able, OT practitioners should strive to infuse occupation-based practice for all their patients, individualizing based on the patient and their unique needs. While both occupations and activities can be used in our interventions, we have a professional duty to strive for interventions that are close to occupation-based as possible. OT practitioners in the acute care setting must balance the values and needs of the client within the constraints of the environment and take up the challenge of innovative adaptations or modifications to kind of best approximate participation in the occupation. As we know, there's definitely value of occupation. Occupation is motivating and meaningful and can therefore be more effective in facilitating recovery. Occupation can decrease risks of hospital-acquired delirium and deconditioning. Occupation can support mental health during what is often a very stressful life event. And occupation can help reduce the risk of readmissions by focusing on functional needs required to optimize post-discharge safety. In terms of some general tips for encouraging occupation-based practice in acute care, you can have families and caregivers bring in everyday items from home. This could be things such as the patient's favorite pillow, blanket, some family photos, so they have familiar faces looking at them in the room, their own toothbrush, maybe some religious items, making sure that people know their favorite music. You can help facilitate the patient to leave the hospital room and encourage meaningful engagement within the hospital environment. And this is going to be patient by patient specific if they're medically appropriate to leave their room, but you can bring them to a kitchen unit if you have one in your hospital, or to the gift shop, cafeteria, to the coffee shop, to the mailbox, kind of any of these different IADL type activities. You could also create occupation kits. For example, you could have a childcare one that might have a bottle, a diaper, a doll, a onesie, pacifier, so patients can engage in maybe some childcare tasks they might have to perform at home. You could have a medication management kit that would have a pill box, pill bottle, simulated pills, medication labels, so they can practice these medication tasks, maybe simulate what they'd have to do for home. You could also have a sleep kit that would have a sleep mask, earplugs, maybe a list of sound machine apps, lavender lotion to help facilitate that occupation of sleep. We know that occupations is a very important aspect of OT, but definitely one that can be very challenging in the acute hospital setting. There are some barriers which we've already discussed, but some ways you could help facilitate it. You can just go into the clean supply room and kind of take stock of what's available and try and use our unique skills of innovation to see what you can simulate to help the patient engage in these tasks. If you have space within your department, maybe you can designate a specific closet for more ADL items so that you can have like an ADL closet and keep more supplies and things there. We wanted to provide a few, two little examples of what we could maybe do within the hospital setting, but say you have a patient that really enjoys fishing. You can make a fishing pole out of tongue depressors, tape them together. You could attach O2 tubing to that fishing pole for fishing line, and you could draw some fish on a whiteboard and then have the patient try and cast the pole to catch the fish. You can generate goals tied to this task, such as the patient will cast fishing pole and standing with less than 2 losses of balance. Another example could be bowling. This could be done maybe in a seated or standing position, but you could use just cups as bowling pins. You can put in tubes of toothpaste to help weigh down those cups. You can make a bowling ball by rolling up and taping a towel, and then have the patient roll the ball. And again, you can maybe make some goals that are specific to this task, such as the patient will add points from bowling game to determine final score with less than 2 cues. And we know that every hospital is going to be a little different and the supplies that are available will vary greatly. But as we said, you can kind of just look in the clean supply closet to get a little bit creative. I don't know if anyone has any examples of an occupation-based activity they've done in practice. They can add into the chat box and kind of see what other people have been doing. But now we are going to move on to how to be prepared, and Colleen is going to take over.
Thanks, Jessie, and I'll try to communicate as needed if you can't read my mind for when to advance the slides. So we're going to talk a little bit about preparedness now after we've reviewed best practice. So many of these areas working in acute care are challenging to learn about and master prior to entering your job. However, using strategies to learn and analyze labs, review reports of and looking at imaging, understanding different medications patients are on, monitoring and interpreting vital signs and trends on hospitalized patients is part of what might feel like a very steep learning curve, but critically important in working in the hospital. So you can consider keeping a document or a journal, writing down frequently seen medications or important lab values for the patient population, such as liver function tests for patients after a transplant, or complete blood counts or CBCs for patients on your oncology unit. Seeking out colleagues who are good at reviewing these sorts of things and perhaps reviewing radiology reports with them and discussing your interpretations and some of the implications from those interpretations together. There are often assessments we learn about in school that we may not recall or have access to in the hospital, as Jessie was alluding to. So advocating for your needs and resources supports preparedness, as well as subsequent best practice if we can have the resources that we need in the areas that we need them. There are certain assessments that you might find yourself using often. I know at my hospital, we use the 3D Camelot, MOCA, SLUMS, the Cognitive Performance Test. So there's certain tools that we seem to lean into a little bit more that are perhaps easier to bring into a patient's room because we aren't able to take patients out of a room depending on medical appropriateness and hospital policies and those sorts of things. There are also a variety of resources that can help prepare you for practice in acute care or practice working with new populations in the hospital, which we'll provide some examples of as we move along, including reviewing journals and OT magazines, returning to some acute care textbooks, joining different OT communities like this incredible community, different social media options, continuing ed courses, websites and podcasts. Or you can consider creating or joining special interest groups. Like I was mentioning at the beginning, I found there was a huge gap in our region, despite such a high concentration of acute care OT practitioners. So I created a special interest group when I was earlier in my career because I was looking for that support and resource option for our state of Massachusetts. And we meet every few months and talk about new patient topics, interest areas, and have the opportunity to collaborate with local practitioners. So as I was mentioning, some of the resources that we'll include are some podcasts, websites, and journals. So some of the podcasts that we have here are my OT Spot blog, OT Flourish podcast, and Spill the OT podcast. And in a lot of these resources, we've included QR codes for those of you that are listening after the fact, or for those that are here and would rather, return to the recording later. And then you can scan these QR codes through your camera on your phone and gain access to these different content areas. So we did that here for the podcasts. For websites, so we've included Jessie's incredible resource website in ICU with Jessie that I still go to quite often. My OT Spot, OT Miri, OT Potential, and OT Focus. And then we've also included here, I think it's about 8 journal articles without QR codes that act as good resources as well. And many hospitals have access to libraries and/or librarians who can help you gain access to different journals if you're unable to access them yourselves. I know some schools you lose access after you graduate and so forth. So seeking out people who might be able to help you stay current with some of this information and preparedness. Okay, so as acute care practitioners, it can be challenging if you work in a remote area, if you lack access to resources and support, or perhaps you're the only OT in your department, your hospital, or even your region, depending on the size of your area. So some things to consider seeking out or establishing at your facility could include creating a mentorship program in your hospital where more seasoned OT practitioners can help mentor newer OT practitioners, or OT practitioners entering a new unit or patient population, because sometimes you may feel like you've mastered one area and then you're floated off to a different unit and it's a whole new population and a whole new area of things to learn. So seeking out some of that mentorship. And yes, it's great if you have access to that mentorship in your own hospital, but perhaps you don't. So then reaching out to other OTs in the region or even virtually and seeking out OT mentorship internationally or nationally for what might work for you. Creating orientation checklists or protocols to support appropriate orientations and thorough onboarding of new hires. Having more senior staff follow therapists for a day on their units. And that can help assess how you're doing on your rotations and can provide more pointed feedback and guidance for best practice with the patients that you're working with. You could create a journal club or a lunch and learn to stay current with evidence for OT practitioners on your staff, or even virtually as well if you connect with others in the regions you're working. Or presenting interesting cases or lessons learned to provide the best care for your patients moving forward. Oh, documentation can always be a daunting area, but some time-saving strategies we've learned a little bit along the way, creating templates or macros or smart phrases if you use Epic. I'm unfamiliar with different documentation platforms around the country and around the world. But sorry. So creating those different sorts of templates and macros can make it easier for you to come up with things to say if you're in a pinch, or if it's a new population and you're uncertain, you can reflect back on some of the more general macros and phrases so that you can individualize it to the patients that you're working with. And then having templates or macros for different types of sessions, such as evaluation sessions that are quite more thorough documentation versus treatment sessions that may be a little bit more concise. Keeping running lists of goals that you pull from when writing evaluations and then individualizing to the patients that you see. I found this to be really helpful, especially when I was working with lower level patients, and I couldn't quite come up with something for someone to do that couldn't get out of the bed in that moment, or was really delirious and couldn't participate cognitively in a session. And so leaning into those lists of goals could be helpful. And then Kate, I see there's a hand up now. I don't know. Should we tackle
Is
this?
that Emmanuel from the UK? Who is that?
Yeah, yes, please. You reached where I wanted to be. That's the documentation part. The documentation, like you said, can be very, very, I don't know how to coin the word now, because different places with different ways of documenting. I moved from a Jerry Auto unit to a mental health because I've always worked in a mental health unit, but mental health in the UK. So now what we do is more of like a Mohost documentation. And I got a bit of pressure in terms of how you document, and of which we've got different styles of documenting, especially if there's a body of framework there. So, but I wanted you to point me in the right direction in terms of maybe resources on where we get putting on documentation, but you mentioned a few, so I don't know if there's more in terms of the documentation, especially in the formulation of your treatment plan. So because, the Mohos can be the Mohos can be very direct, in terms of, you just assess using the FAIRS, and saying what the patient has demonstrated. But in terms of also formulating in terms of giving like recommendations, and because you can't directly say you're recommending this person is going to a care home, you're recommending this person. So you just put it out there, especially with the system which we operating in the NHS, in terms of you putting it out there for the care coordinator to look at what is best. So I'm just trying to see if there's a way you can point me in the right direction in terms of getting more resources and documentation. Thank you very much, Colleen.
Of course, that's a great question, Emmanuel. And I think it's challenging because it can be so city, state, region, country specific, depending on what documentation systems you have, what policies and procedures and liability and billing requires for different reimbursement purposes. So I think what's really important is understanding the policies and the requirements of your own facility, and then leaning into your state and national associations and if they have any resources available. I know Jessie's been working on a special documentation certification course that's going to provide some additional information for documentation learning. I know AOTA has some things on their website that potentially you could look into, Emmanuel, because it's online rather than accessing in person sort of thing. So
thank you.
Yeah, sure. And then when you find something that works for you, keeping track of it and sharing it with other people, I think is really important.
Definitely.
And then you'll see here in this picture, you can consider creating and providing an evaluation cheat sheet, which makes it easier to write down what's happening during your sessions to ensure both thoroughness and to help you not forget things when you're coming out to document, or things you need to ask and remember when you're in the room as well. So I've created this kind of over the years with some of my students as they're learning in their clinical rotations. Okay, so here we have a case scenario, just one very small snapshot in a massive world of patients that we see. So this is a 72-year-old male with a history of cirrhosis in his liver, hypertension, type 2 diabetes, who was brought in by ambulance after he was found down by his wife. On his exam, he had what's called positive asterixis, or can kind of generalized be like shaking in his hands, suggestive of cirrhosis, which is decompensated by what's called hepatic encephalopathy, or confusion related to liver failure. So this patient is admitted for ongoing workup and management in the hospital. So then we're going to think, what could some of the best practice considerations be for this patient in this example that we have? This is certainly not all inclusive, but intended to get our wheels turning a little bit. So some labs we might consider for this patient would be blood values and liver function tests and his ammonia level, which is directly related to his hepatic encephalopathy. And then as well as what's called his MELD score, or the model for end-stage liver disease. And the higher the score is, the worse his liver dysfunction is. And that can impact perhaps how confused he is or what his treatment plan might be. Some vitals for this particular patient would include blood pressure, heart rate, respiratory rate, and his rate of perceived exertion. And that can really guide how we're grading our treatment session in that moment, and depending on what his self-reported RPE is. What might we be advocating for? I would think a social work consult, a PT consult if his mobility indicates that this would be necessary, a pharmacy consult to see if his medication regimen could be simplified for easier compliance, talking to physicians about the importance and our role for OT in relation to this consult. In acute care, we're almost always asking the question about what his medical plan is, not only for that day, but also more long-term in his stay, as well as his timing for discharge, because this can impact the extent that we need to cover in that initial consult or evaluation versus being able to plan for a follow-up session where we might implement or assess further things. And talking to and asking questions from his wife who brought him in about what's going on at home that was leading up to this hospitalization and the needs that this particular patient might have, especially if his confusion is precluding him from providing that information. Some assessments we might consider for this particular patient are an informal cognitive assessment, medication management assessments to see if he understands and can support compliance with his medications. Like one particular medication is called lactulose, which helps with hepatic encephalopathy. And if he can't manage that medication, well, then that's a major challenge for him. Formal cognitive assessments such as a clock draw, trails testing, recall, tests of attention. So some of those executive function higher level tests to see how his thinking is impacting his function. And then what might be next for him, or this is a more bird's eye question we should be asking for a lot of our patients. We want to make sure we feel prepared with an understanding of his diagnosis and side effects before we go into the room. And then thinking about our plan for when we're in the room, and then how to create the safest and most effective discharge plan is really the golden question that we're asking as acute care practitioners. How do we get this patient out of the hospital to their next level of care, whether that's home or rehab? So again, we'll take a little bit of a bird's eye view of this case. And what this case could look like from an assessment and intervention standpoint, and then potential outcomes as a result of our preparedness and our implementation of best practice. So for example, with this case, given the patient's hepatic encephalopathy or his confusion related to his liver dysfunction, OT would perform formal and functional cognitive evaluations with memory, attention, executive functioning, specifically assessed in the setting of his confusion, as well as a medication management assessment, such as it's called the Manage Med or the Medicog assessments. Often, as I was saying, this population struggles with med compliance and understanding, especially related to the importance of that lactulose medication and mitigating his confusion. So therefore, we could help counsel the patient and his wife on the role of those medications, not from the lens of being a pharmacist, but from our own particular OT lens. Compliance strategies for increased independence and compliance with his medication routine, and some signs and symptoms from a medication education standpoint about hepatic encephalopathy to potentially reduce his frequent readmissions, which then would decrease length of stay and more systemic impacts that are pretty powerful from a systems level. And we could introduce different med assistance resources like apps on his phone to help him better manage, pharmacy modifications through communication with the pharmacy team, adaptive equipment, and then thinking about some post-discharge planning like OT and BNA services that might be able to help him and his wife be more successful at home. We could ensure the patient and family understand the implications and this education, and then, like I said, have the most safe and optimized discharge plan moving forward. So Jessie and I are hopeful that you found this presentation to not only be informative, but also to be a little bit helpful. And we'll take time to go back to some of the resources provided as you continue along your acute care OT journeys. Working in the hospital can be pretty intimidating and overwhelming, but it can also be really exciting and really rewarding too. You have the opportunity in the hospital to learn and apply a lot and make differences in patients' and families' lives, and create collaborative relationships with different hospital colleagues and different medical providers, and learning a lot about yourselves and your practice, but learning a lot about other practices and interprofessional opportunities too. And something that we've come to learn about is what I've kind of coined as confident humility. You'll grow to feel increasingly confident and comfortable in the acute care setting, but it's really also okay to recognize that you are likely never truly an expert in acute care, even after years of practice. We both see new diagnoses, new procedures. There's constantly new research coming out, not only from OT, but from the medical world in general. And there's continuous new innovations in this acute care setting. So things we've never seen before, and we're continuously looking into things, looking things up, asking questions. And that's a good thing, to always be seeking out those answers and asking those questions, especially with this particular setting. So we wish you the best and are always open to connecting. We can share that information if you would like. And we want to thank you so much